Good morning, everybody. Apologies for the slight delays with our fun tech stuff. I have the privilege of introducing Dr. Michael McDermott this morning, who's giving us a talk on thyroid nodules. Most of you probably already know him. He's been a fixture around here and a leader in endocrinology. He is definitely my go-to person for all questions endocrinology. So he actually attended college at Georgia Tech, did medical school at Tulane University, then did residency and fellowship at the Fitzsimmons Army Medical Center. And he's the former consultant to the Surgeon General for endocrinology and ad hoc endocrinology consultant to the President of the United States. So it's an extreme privilege to have him present to us today. Thank you.
Thank you, Rita. Well, I'm pleased to be here, and I hope all of you can hear fine from the remote locations. So Brandon asked me if I would speak on these thyroid nodules, these little rascals that we seem to see all the time on ultrasounds or during physical exam. And so they do bring up a lot of different questions. But I do have to say that the guidelines for management of thyroid nodules are currently in revision. I thought they would be done by the end of 2024, but they're not. So there's still some new recommendations that I won't even know about that I can't tell you today. But this will be, for the most part, I think a very good way to approach thyroid nodules, whether you find them during an exam or incidentally during imaging procedures. So I don't have any conflicts of interest to disclose. My current learning objectives are first to explain the evaluation to determine if a thyroid nodule is causing hyperthyroidism, because some of them do, and they're always benign. And then it's a different ballgame. Discuss how to evaluate if a thyroid nodule, even if it is benign, if it's compressing the esophagus or trachea. And then what we're all interested in is the diagnostic approach to determine if a thyroid nodule is malignant or benign. So how common are thyroid nodules? If you felt everyone's thyroid gland that you saw, you would find a thyroid nodule in about 4 to 7% of people. If you did an ultrasound on everyone, just screening type ultrasounds, 13 to 40% have thyroid nodules. So they're very common on imaging procedures. And that's why when you order a chest CT for something else, one of the most common things is say, oh, by the way, there's a thyroid nodule. And during autopsy series, at least 50% of thyroid glands during autopsies have thyroid nodules. So they're pretty common. I tell people it's kind of like your skin. It's not perfect. If you look at all of your skin, you got something somewhere. And it's true of the thyroid gland as well as the adrenal glands, by the way. So the prevalence of thyroid nodules does increase with age. So as people get older, you're going to find more than I have listed here. The differential diagnosis, first of all, is, are these benign or are they malignant? And we'll talk about the other questions in a moment, but the benign ones are far more common. Less than 5% of thyroid nodules are malignant. So the benign ones are usually a colloid nodule. They're just full of colloid. They can be an adenoma, which are full of cells, but they're benign. They can be a cyst that's just full of fluid. It can be inflammation in the thyroid gland from COVID, for example. We saw a lot of that. It could be a lymph node. It may not even be a thyroid nodule, or it could be a parathyroid adenoma because the parathyroids are next to the thyroid, and many of them are embedded within the thyroid gland. So it just could be a parathyroid adenoma. Now, the malignant ones are the common cancers we know: papillary, follicular, Hürthle cell carcinoma, medullary, and anaplastic, but also thyroid lymphomas are becoming recognized more often. And then metastatic carcinoma, the vascular thyroid gland, is a common site for metastasis from certain types of cancer, especially renal cell carcinoma. So when you see a thyroid nodule, whether you've discovered it during a physical exam or it was incidentally discovered during imaging, there's 3 questions you need to ask. The first one is the nodule causing hyperthyroidism, because that's a different ballgame. It's benign, but you need to manage the hyperthyroidism. Second, is it causing compressive symptoms, whether it's benign or malignant? We usually need to do something about that. And third, is it cancer? And that's the patient's main question. Okay, so we'll start with a case, and I'm the MD in this case, but I was watching a show that I like, and being a thyroid nerd, I noticed that this actress had a lump in her neck. Um, and it was fairly prominent. And so I tried to look her up on the internet. And of course, you can't get a hold of people that way, but I did send a letter to her agent who told me I'm going to send her to her primary care doc and did so. And this was her result. She had no history of radiation therapy, thyroid disease, no family history of thyroid cancer. She had a good physical exam, but she had a 3 centimeter left thyroid nodule. So the first thing is, what do you recommend? Now you have a 3 centimeter nodule. What's the first thing you're going to order? A TSH, a thyroid scan, a thyroid ultrasound, or biopsy? And the first thing you should order is a TSH. Okay, so a TSH was ordered on her, and that's how we get into deciding, is this nodule causing hyperthyroidism? Nodules that cause hyperthyroidism are benign, but you need to manage the hyperthyroidism. So her TSH was undetectable, and her free T4 was elevated, and her total T3 was slightly elevated. So it looks like this could be a functioning toxic thyroid nodule. So what do you recommend now? You do a thyroid lobectomy, do an ultrasound at this point, a thyroid scan and uptake, or an FNA. Now, when I was training, we did a scan on everyone who had thyroid nodules, but now we only do them on people who have low TSH levels. So she needs a thyroid scan to see if the nodule we're feeling is actually functioning. This isn't her scan, but it is a scan that would be similar to the one that was in her chart. And it's a functioning thyroid nodule that's making enough thyroid hormone to suppress TSH so the whole rest of the gland doesn't show any of the imaging material. So that's a solitary functioning thyroid nodule. So a toxic thyroid nodule is what this lady had, and that's actually a fairly common outcome when you're evaluating a thyroid nodule. So on physical exam, you'll find a solitary, not multiple nodules. If you do a radioactive iodine uptake, which you should do if the TSH is low, the radioactive iodine uptake may be elevated, as it was in this case, but it may be normal. But remember, if the TSH is low, that thyroid should have no uptake whatsoever, because TSH is the only physiologic stimulator of the thyroid gland. So a normal radioactive iodine uptake in the context of a suppressed TSH is actually abnormal. So it'll be high normal or normal and solitary uptake, as I just showed you. The way we treat these, you can put them on antithyroid drugs like methimazole or propylthiouracil, but these never go into remission. It's not like Graves' disease, where half the people you put on an antithyroid drug, a year or two later, they're in remission. These never go into remission because they're autonomously growing nodules. They're neoplasms. But you will bring their symptoms under fast control. So if they're symptomatic, you may want to try an antithyroid drug. You can give radioactive iodine. The radioactive iodine will radiate the nodule, but not the rest of the gland. And so only about 50% of people get hypothyroid after radioactive iodine therapy. In Graves' disease, everybody gets hypothyroid because the whole gland gets radiated. These people, about half of them. Or you can take the nodule out. And since you only take the nodule out, and usually that lobe, only about half of the people will have permanent hypothyroidism. So about half the people that get treated for these will not be on thyroid hormone therapy forever. The next type of nodule this man has is a 63-year-old man who's been having mild weight loss, neck discomfort, and some intermittent difficulty swallowing. He has hypertension and takes medications for that. He's a little hypertensive on his exam. His thyroid gland is about threefold enlarged, and it has multiple nodules, not one. His TSH is undetectable. That triggered measurement of free T4, which was elevated, and a total T3, which was also elevated. So he also has thyrotoxicosis. And here was his scan. So instead of having a solitary nodule, as that previous patient had, or diffuse uptake, as someone with Graves' disease would have, he has multiple hot nodules. So this is a toxic multinodular goiter. And these are treated just like thyroid toxic solitary nodules. You'll find a multinodular goiter on your exam. The radioactive iodine uptake will be high. or high normal, and the scan will have heterogeneous uptake like I just showed you. The treatment options, you can put them on antithyroid drugs to control their disease. That's all it'll do. It won't ever put them into remission, but it will bring them into euthyroidism. You can give radioactive iodine because only the hot nodules take up the radioiodine. They're the only ones that get destroyed. And so only 50% of people get hypothyroid. And you can do surgery and only about 50% get hypothyroid. So the other 50% will not be on permanent thyroid hormone therapy. So those are the functioning solitary and multiple nodules that we find by measuring simply a TSH. It's undetectable. We go down this pathway of a radioactive iodine uptake and scan. The next question, though, is does the nodule cause compressive symptoms? So compressive symptoms, we ask people, do you have trouble swallowing? Do you have trouble breathing at night? Do you have hoarseness? So this is a 56-year-old woman who's from Europe, and certain parts of Europe have goiter belts, especially in the Alps, where the so in the United States, most of our land was under the sea at one point, and so we have a lot of iodine in the soil here. We don't have much iodine deficiency, but the Alps are older, they're high, it was never underground, and so they never had seaweed, they don't have salt, they don't have iodine in their soil. And so iodine deficiency is common in certain goiter belts in Europe. So she had moved here after she met her husband who was stationed in Germany, and she had a goiter, and she was complaining of hoarseness, difficulty swallowing, and neck fullness. Her physical exam showed a pretty large thyroid, about 4-fold enlarged in multiple nodules. But her TSH was normal. So that told me that her thyroid gland, these nodules, were not functioning. They were just growing. They were big. So she had a neck ultrasound. She had a very large goiter with multiple nodules, and 2 of them were very large, 2.3 and 2.8 centimeters. They had no suspicious features, but because of their size, an FNA was done. They were both benign colloid nodules. So she doesn't have cancer. Not worried about that, but she does have these symptoms. So what would you recommend to evaluate symptoms that you think might be due to an enlarging goiter? A thyroidectomy, radioactive iodine ablation, repeat FNA and do molecular markers to make sure it's not cancer, or do a CT scan of the neck to assess for obstruction. And that's the answer. We should do a CT scan. It's the best way to look and see if a thyroid nodule or the whole goiter is compressing the trachea or the esophagus, if it's sneaking down behind the sternum or causing any other mischief anywhere else. So a CT scan is the best way to assess for that. So nodular goiters are goiters that have multiple different nodules, and these actually start out as diffuse non-toxic goiters. Just the gland begins to enlarge, and over time, they develop nodules and become a multi-nodular goiter. So here's a photo of a young girl from one of the areas in Europe that's a goiter belt. And in this particular town where she lived, this was common. All the kids had these diffuse goiters. Okay, so they didn't have enough iodine in their region, and they were developing goiters. That's not the only cause of goiter, but it's a good example of what stimulates one. So early on, they have diffuse goiters. And although this isn't the same village, I just showed this for effect, but this is a woman from Bolivia in a very severely iodine deficient area whose goiter would have started out like that when she was a young girl and just progressively enlarged. The woman in this picture is euthyroid. She has normal thyroid function. It's just that she's had to have her thyroid enlarged dramatically over the years in order to produce enough thyroid hormone to make her euthyroid. So what causes non-toxic goiters? It's usually inefficient thyroid hormone secretion, not hypothyroidism. In hypothyroidism, the gland is usually inflamed from Hashimoto's disease, and it gets a little bit big, but not huge usually. But these are people who have a mild deficiency of hormone secretion. So their pituitary gland makes more TSH. TSH stimulates the thyroid to grow, and it grows until it's big enough to absorb enough iodine and make enough thyroid hormone to keep the person euthyroid. The most common cause worldwide is iodine deficiency. But also there are certain areas of the world where there's goitrogens. And so on the coast of Japan, they don't have iodine deficiency. They have iodine excess. They eat a lot of seafood and they eat a lot of iodine containing plants from the ocean, and they have iodine excess and they get goiters too. People who take lithium, people who take amiodarone, there's a number of medications also that can cause goiters. And finally, some people just inherit this tendency to make thyroid hormone inefficiently, not enough to cause hypothyroidism, but enough to cause chronic TSH secretion, and their gland grows progressively. So the clinical features, people complain of a mass sensation. I feel like there's something in my throat, and especially if they put on a tight collar. They have dysphagia. They have difficulty when they swallow. Often food sticks here rather than lower, and they have hoarseness. The signs, they frequently have a palpable goiter, although sometimes a substantial portion is substernal, and so you may only feel a little bit up here at the top. They often do have superior vena cava obstruction because once the goiter's behind the sternum, it can't go forward. It has to grow backwards. And what's right back there, the superior vena cava. And so they will frequently have Pemberton sign. So what is Pemberton sign? So here's a guy with a big goiter. It's got a substantial substernal component. And Pemberton sign is when you raise your hands above your head, you get this line of suffusion where the face gets red and then it cuts off due to superior vena cava obstruction. So that's called Pemberton sign. So it's a good sign to do if you've got somebody with a big goiter right in front of you. The management of non-toxic goiters. If they are asymptomatic, they can just be observed. Some of them never grow. They're just there forever. If they are causing compressive symptoms, the only treatment is surgery. There's nothing else. So levothyroxine suppression was done for years. We used to give people thyroid hormone, say, well, if your gland doesn't have to work, it'll shrink. But that doesn't work. These are autonomous nodules and they don't shrink. So don't treat these with levothyroxine unless the person's actually hypothyroid. You can give them radioactive iodine, and occasionally I've had patients who needed surgery but were poor surgical candidates, and so radioactive iodine is an option. It'll reduce a multinodular goiter by about 30%, so it'll shrink, and that may be enough to free up the trachea so that there's no more difficulty breathing at night, or it may free up the esophagus to relieve dysphagia. If you give radioactive iodine, the whole gland will take it up. About 50% of people get hypothyroid. And interestingly enough, about 5% actually get Graves' disease. The radioactive iodine causes release of antigens that stimulates Graves' disease formation. Okay, so the answer or the question that most people want to know, but I think it's critical to answer the first two questions. Is this nodule function and cause it hyperthyroidism? Does it compress, whether it's benign or malignant? But now we want to know, is the nodule cancer? And that's usually the biggest question for the patient and the referring doctor when we see them. So this 34-year-old woman is found to have a right thyroid mass on her annual exam by her primary care provider, and it was asymptomatic. She had no history of thyroid disease. She had no history of radiation therapy to the neck, and that's one of the risk factors we'll talk about. And no family history, the other risk factor. Her thyroid, she had a 3.1 centimeter right nodule, and she had 2 palpable lymph nodes. Her TSH was completely normal. So what would we recommend now? So this was found on physical exam. She hasn't had imaging yet. So the first thing we want to do is a thyroid ultrasound, okay? And the thyroid ultrasound showed that it was 3.3 centimeters. It was hypoechoic, and it was taller than wide, which means it was growing inward rather than side to side. And that's actually more of a bad feature. So what would we recommend now? We've got a 3 centimeter right hypoechoic nodule that's taller than wide, fairly suspicious. Serum thyroglobulin, scan, FNA, or a PET scan. She needs to have an FNA. Okay, so this is a no-brainer here. So she had a thyroid FNA biopsy. And it didn't show cancer and it didn't show benign. It showed this sort of annoying intermediate finding that is fairly frequent called atypia of uncertain significance. It means it's a little atypical. We can't call it benign. We can't call it malignant. So what do you do now? You don't want to go taking all these out. You might, but usually people don't want surgery if it's not malignant. So what would we recommend for some indeterminate nodule like this? A PET scan, thyroidectomy, radiofrequency ablation, and all of these are reasonable, but the best answer would be to do molecular markers. So we have the ability to look at the genes inside a thyroid nodule to predict or tell us definitively, is this cancer? Is it benign? And if it's cancer, is it a bad one? Is it going to be a very aggressive or not aggressive cancer? So she ought to have a biopsy with molecular markers. And she had one, and it showed this is definitively papillary thyroid carcinoma. So she progressed to have, at age 34, with a nodule less than 4 centimeters, she would have a right thyroid lobectomy. So how do we evaluate a thyroid nodule? Clinically, we first want to evaluate what are the things about this patient that increase the risk that this nodule is cancer. Okay, so we start with our history. If they have compressive symptoms or invasive symptoms would be tightness, but compressive, as I said, dysphagia, difficulty breathing, hoarseness, those increase the risk that this is an aggressive tumor. If they've had a history of radiation exposure, so back in the 50s and 60s, they used to actually radiate people's face to treat acne. And they used to radiate the tonsils instead of taking them out in some people. So there's a lot of people that are in their 70s that had radiation therapy back in the 50s and 60s for benign conditions. But we also do radiation therapy for other things like Hodgkin's disease, for example. So a history of radiation exposure to the head and neck significantly increases the risk that this is cancer. A family history. So we know that both papillary and medullary thyroid carcinoma can have a familial tendency, especially medullary. So now we've increased our pretest probability just by doing a history. A physical exam, if the nodule is over 3 centimeters, this lady's nodule was 3.3. If it's firm and fixed, as we know about from tumors in other parts of the body, and if there's cervical lymph nodes present. So with a history and physical, you've established a pre-test probability that's very high or very low that this is cancer. So the first thing you do is measure a TSH. And if the TSH is low, like I said, this is probably a functioning nodule. It's probably benign. So you just go down the hyperthyroid pathway, free T4, total T3, and nuclear medicine studies. But if the TSH is normal or high, they need to have a neck ultrasound unless they've already had one. And the neck ultrasound will tell you not if it's benign or malignant, but whether or not you need to do a biopsy. The thyroid ultrasound assesses the size and the features, and it's actually more accurate than a CT scan or an MRI for evaluating thyroid nodules because the internal architecture is more distinct. And what it does, as I said, is it just determines whether or not you need to send this person for an FNA. The fine needle aspiration will usually come back with one of 3 readings. This is benign, this is malignant, or it's indeterminate. The indeterminate is like the one I just showed you, atypia of uncertain significance. When it's indeterminate, that's when we use our molecular markers. We say, what can the genes inside this nodule tell us? Does it have a BRAF mutation, which means this is cancer? Does it have a BRAF plus a TERT mutation, which means it's a bad cancer? Does it have a RAS mutation, which means it's probably a benign nodule? So we do that when they have atypia of uncertain significance or it's follicular neoplasm. Some of these terms are going to go away. And in the new guidelines, they're going to call these nodules something else. And I don't have those names yet. So right now, that's what we call them still. Now, what are suspicious ultrasound features? You know, I didn't learn to do ultrasounds when I was in training, and when I attend on the medicine wards, residents pull out an ultrasound out of their pocket and ultrasound things. They're really good at it. So I'm sorry that I missed developing that skill. And some of you may have it and be able to look at some of these ultrasounds and interpret them well. But it does take a lot of training. Hypoechoic means it's darker than the surrounding tissue. That's a feature that increases the risk of cancer. Irregular margins, a halo around it, which is edema. Punctate echogenic foci, these are microcalcifications or macrocalcifications, which usually follow an internal hemorrhage. Or they're taller than wide, which means it's growing deep rather than to the side. These are all individual features that suggest malignancy. But what's important is the pattern of all of these together that increases the risk more dramatically. So if you have a hypoechoic nodule with irregular margins and punctate echogenic foci that's taller than wide, now you're building on your malignancy risk. What I just described would have a 75 or 80% chance of being malignant if it had all four features. So we don't look at one feature, we look at the pattern of features. So this is a spongiform nodule, and it's called that because it looks like a sponge. And these are almost always benign. When you see the spongiform features, they're little, they're not invasive. They generally have a smooth capsule, and it's very reassuring. And we hardly ever biopsy a spongiform nodule. This is a hypoechoic nodule. So you can see it's darker than the surrounding tissue. So it's dark, that's hypoechoic, which is one feature, but it's got no irregular margins, and it's not invading. There's no lymph nodes. There's no echogenic foci within it. So even though it's hypoechoic, it's relatively low risk. This, on the other hand, is hypoechoic. It's darker than the surrounding tissue, but it has irregular margins, and it may have a couple of echogenic foci here or microcalcifications. So this one has, even though it's smaller than the previous one, it has a higher risk of being a malignant nodule. And then this is one that has a very high risk. It's hypoechoic. It's got very irregular margins, and it looks like it's invading into the other parts of the thyroid. And it's got multiple echogenic foci here or microcalcifications. So an ultrasound can give you a really good ballpark idea of whether this is benign or cancerous, but it can't give you a specific diagnosis. So this is the patterns that they came up with in the 2015 draft. Brian Haugen, who was previously the head of our division, was a lead author of this paper. This is being revised in 2024. But what all I'm showing you is that they put these into categories. Like here at the bottom is a cyst with a smooth wall, that's benign. Doesn't even need a biopsy. The spongiform nodule, very low suspicion. The hyperechoic, same features or same density as the surrounding tissue, low suspicion. And then we've got our hypoechoic nodules and our ones with microcalcification, with the risk of cancer going up as we go. And so the recommendation to do a biopsy is going to depend on what we think the risk of cancer is based on this ultrasound pattern. Now, there's two different scoring systems. One is the American Thyroid Association, and the other is the American College of Radiology. So I'll show you both of those. But what they do, first of all, is describe, based on the ultrasound appearance, what the suspicion is of malignancy. Is it benign, very low, low, intermediate, or high? For a benign nodule, the risk of malignancy, if it's benign looking on ultrasound, it's got less than 1% chance of being malignant. And we don't recommend biopsying those if it looks completely benign. If it's got a very low suspicion pattern, the next row up on that table I just showed you, it's up to 3% risk of malignancy. And so we biopsy them, but only if they're over 2.5 centimeters and only if we feel like we need to. So that's what you consider over 2.5. The person who reads this should give you these recommendations. If it's low risk, 3 to 20% chance of cancer, we biopsy. If they're anything over 1.5, some people wait until it's 2.5. Intermediate is 20 to 50% risk of cancer. We biopsy it at a smaller level, and a high risk over 50%, but we still want to know what it is. Is it a lymphoma? Is it metastatic cancer? Is it papillary? So we need to know, even though the risk is high, we know we're going to take it out. We still want to do a biopsy to know what it is. Now, the American College of Radiology uses a Thyroid scoring system, and they similarly have benign, very low, low, moderate, or high. And our radiologist here, that's what they read. So this is what you'll get on your report. It's going to be Thyroids, which is what TR stands for, 1, 2, 3, 4, or 5. We only do a biopsy if it's Thyroids 3, 4, or 5. We do a biopsy for a Thyroids 3 if it's over 2.5, Thyroids 4 over 1.5, and Thyroids 5 over 1.0. And that should be in the reading. So the radiologist should give you that reading. Or if we do it in our clinic, that we should give you that reading, what the score is, what the risk is, and whether a biopsy is needed. Now, when we do a biopsy, then there's similarly some uncertainty. So a benign biopsy is usually benign, but the malignancy risk is still about 4.4%. So in some cases, particularly if they're big, you still have to watch these. If it's non-diagnostic, that means you stuck a needle in there, you sprayed it on the slide, and there was no slides. There was no cells. If that's the case, 13% chance of being a malignant, because cancers are more stingy at giving up their cells. If it's atypia, the malignancy risk is higher, follicular neoplasm higher still, suspicion, and malignant. So this is the pathologist report of the FNA that we do. Now we've got our ultrasound features, and now we've got our FNA biopsy. But we still have these in the middle that are not certainly for certain cancers, so we have to do even more. So what do we recommend? If it's a benign biopsy, monitor it clinically and by ultrasound. And I'll tell you more about how often. If it grows, then we need to do more work. If it's non-diagnostic, we do another biopsy. If it's atypical, we do an FNA with molecular tests, or if you and the patient are concerned with shared decision-making, you may do a diagnostic lobectomy where you just take it out. Or it may be a person who doesn't want anything done and you say, let's just observe it. So all of those are choices depending upon your opinion and the patient's. Follicular neoplasms, we almost always do molecular tests or a diagnostic lobectomy. Suspicious, you do molecular testing or we just go to a lobectomy. And if it's clearly malignant, if it's under 4 centimeters, a lobectomy. If it's over 4, we do a complete thyroidectomy. Now, you may get a report that says the criteria for an FNA are not met. That usually means it has some features that may be benign or may be suggestive, but it's too small. We don't biopsy any nodule under 1 centimeter. So what this usually means is these are sub-centimeter nodules. Okay, so what do you do when the radiologist says the FNA criteria are not met? If you send that to us or if you send it to IR, we're not going to biopsy it. Okay, so what do? It depends on the ultrasound pattern. Even though it's too small to biopsy, it could have a very benign pattern or it could be very bad looking. So if it's a high suspicion and less than 1 centimeters, repeat that ultrasound in 6 to 12 months. If it's low or intermediate suspicion, which will be on the report, but too small to biopsy, repeat in 12 to 24 months. Very low suspicion and over 1 centimeter, repeat in 24 months. Very low suspicion and less than 1 centimeter, you don't need to do a repeat ultrasound. Now, what do you do with benign cytology? When you've had the biopsy, the last slide was when they say you don't even need one. This is when you've done a biopsy and it's benign. Again, 4% of those still have a risk of malignancy. So if the nodule has had a repeat ultrasound guided FNA because it grew and the second biopsy is benign, you don't need to follow that anymore with ultrasound surveillance. This is a draft. These recommendations are what I think are going to be published in 2025, but I'm not sure. If a nodule has benign cytology once or on a second biopsy, but remains stable in size over 5 years, you can stop doing ultrasounds. And an ultrasound should be performed if your clinical assessment suggests that the nodule is growing. And I had a lady not too long ago who had had multiple biopsies. They were benign. She had molecular testing. It was benign, but it was growing. We took it out and she actually had a follicular carcinoma. So use your clinical judgment. Feeling that thyroid is critically important. And if you think it's growing or they're developing progressive obstructive symptoms, then further evaluation or surgery is needed. What if it's one of these atypical cytologies and we don't do surgery? What are you going to follow up? It also depends on the radiology pattern. So it's atypical, but the person didn't go to surgery. If it's a very low suspicion pattern, just keep doing ultrasounds. If it's low or intermediate, we usually do a repeat FNA for cytology, and we do molecular markers. And these are getting more and more accurate. And we know that we use molecular markers also in colon cancer and breast cancer. They give us a lot of information about whether a lesion is cancer or not, but also how is it going to behave? Is it going to be a really aggressive or sort of an indolent cancer? And if it's high suspicion and it's atypical, or if it's growing or compressing, or the patient just says, I want this out, which a lot of patients say, if you think it might be cancer, take it out, then just send the patient right to surgery. Now, molecular markers, as I mentioned, are really very useful, and it's a huge industry. When you go to national meetings like the American Thyroid Association, the Endocrine Society, there's huge booths of these people that have different molecular marker panels that we can use to evaluate different types of cancer. They often have all kinds of candy and popcorn there to attract you to go and see their stuff. Afirma GSC is really good for telling us if a lesion is benign. It doesn't have malignant markers, but if it's benign, you can rest assured it's benign. The ThyroSeq V1 and the ThyroSeq Gen Next Tyra MIR are more geared to telling us if they have malignant mutations. So these are very useful, and I think as we learn more and more about them, they tell us a lot more about, first of all, does the patient probably have cancer? How aggressive does the surgery need to be? After surgery, do we need to use radioactive iodine or not? And might we need to use kinase inhibitors in the future? So I'm going to summarize the thyroid nodule evaluation. First of all, you've detected this thyroid nodule by history or by exam, and you've already measured a TSH, the first test that we do. If the TSH is normal or high, we know it's not a hyperthyroid nodule. We have to evaluate it for compression or malignancy. So you do a neck ultrasound and look at the size and the internal features, and those will tell you if you need to do a biopsy. If it's small or the features are completely benign and you don't do an FNA, monitor. We usually repeat an ultrasound 1 year later, 2 or 3 years later, and then maybe never again. If the ultrasound says you need to do a biopsy, you do that. If it's benign, we monitor. If it's atypical, we do molecular markers or monitor. And if it looks like thyroid cancer or highly suspicious, we do surgery. Now, if that TSH is low, then we want to do a free T4 and a total T3 and nuclear medicine studies to see if it's a functioning nodule. If it's a functioning hot nodule, we're going to treat that person for hyperthyroidism, usually with surgery or radioactive iodine, or in some cases, long-term antithyroid drugs. But if you do a scan and the particular nodule that you're concerned about, maybe there's some hot nodules in some parts of the gland, but some are cold, then you have to treat those as we do those that are non-functioning. So we would want to look at the ultrasound features and consider whether or not they want to have a biopsy. So within a gland where a person has hyperthyroidism, there can be functioning nodules, in association with a cold nodule right next to it. It's the cold nodules that aren't functioning, that don't have sufficient differentiation to produce thyroid hormone, the ones that we need to evaluate for thyroid cancer. So I'm going to stop here. I've gone through, I think, what's a practical approach that I use, and I think that people in primary care should use in evaluating thyroid nodules, whether you've discovered them at a physical exam or whether you've found them incidentally, which is how I think we see most thyroid nodules nowadays. So I'll stop and answer questions.
There's a question in the chat. For a patient with high risk factors, for example, like mental radiation, and a nodule that has been biopsied twice, but is still growing, do you stop monitoring those as well, or only in low risk?
So only in low risk patients. Nodule growth is always important. I would stop if it's benign and there's no growth, but if they're growing either by physical exam or on repeat imaging, you have to take that seriously. And the story I said a minute ago, biopsy, 2 biopsies, both benign, molecular markers benign. It kept growing. It turned out to be a follicular carcinoma. And that lady had actually metastases to bone. So that would, that it just shows you that if it's growing, if you need to pay attention to that.
Can you repeat the question just for the Zoomies?
So the question that was just asked is if a nodule is benign but growing, and you do another biopsy and it's still benign, do you stop monitoring? I think that was the question. If it's growing, you have to continue to monitor. If it's benign and it's not growing, then you can stop.
Can you say a little more about when you decide to stop getting follow-up ultrasounds on nodules? It seems like radiology always recommends another follow-up regardless of stability or
the radiology reports do always recommend continued follow-up. So the question is, when can you stop doing follow-up? And the 2025 guidelines, which aren't out yet, are going to address that in a lot more detail because they felt like the previous guidelines didn't address it adequately. So I've been to a presentation where they talk about what they might be, but they're not finalized yet. So, and I think I showed one slide that showed if you have a nodule that's been biopsied twice and it's benign and it's not growing, you can stop doing an ultrasound. If you have a nodule that's sub-centimeter and has low suspicion features and it's not growing, you can stop doing ultrasounds. But if they're growing or they have a more suspicious feature on them, and that's going to be part of what the guidelines delineate when they come out finally, then you need to keep monitoring those. So, and part of that too is how concerned is the patient? Some people you say, we don't need to do anything more about this because this is benign, and they're happy with that. And there's other people that say they call me before their annual visit. I want an ultrasound and my thyroid test done. And if you don't, they don't feel reassured that their nodule is okay. So I think to some degree guidelines are good, but you sitting in front of the patient and doing shared decision making, it may not be always cost efficient, but if it relieves anxiety in the patient, then you may want to continue getting ultrasounds, maybe not annually, but every 2 to 5 years, just so the patient is reassured that they're not growing. Yeah. So the question is, does age have anything to do with how aggressively you pursue these? And I spoke at the ACP on this last year, and that same question was asked because it's a critical one, and the new guidelines are going to address that in more detail too. But an anaplastic thyroid cancer is the most aggressive cancer known, and people die in 6 months. So that would be one, but that's rare. But if people die of thyroid cancer, it's usually 15, 20 years later. And so keeping that in mind, if you have somebody that's older and the likelihood that this nodule is ever going to cause problems that's going to shorten their life, you can change that strategy and say, you're 80, we can just monitor this. So it does play a big role, and that's going to be better delineated in the new guidelines. But you hit the nail on the head. Look at the patient. If their life expectancy is relatively limited, then you really don't need to pursue a cancer that in most cases is going to be fairly indolent, and still going to be there 20 years and not have done any harm to the patient. Yeah. Yes. So the current guidelines are not to, and then there's some sub-centimeter nodules that have some really nasty looking features. And it would be very difficult to explain to somebody why you're not going to biopsy it when it's got microcalcifications and irregular outlines and a lymph node right next to it. And one of the docs in town that had a nodule that fit that description exactly, she was saying, "You're not going to biopsy this nodule?" And we said, "Yeah, we are." And we did. And sure enough, she had thyroid cancer. And we took it out and did molecular markers, and they predicted she had a BRAF and I think a TERT, which predicted that if we had let it grow, it would have been more aggressive. So yeah, I would say that, again, guidelines aren't rules or laws. They just give you guidelines. But if you had an 8 mm nodule that had some bad features, I think you'd have a hard time telling a person, no, we're not going to do anything with that. And we can easily, they're not too small to biopsy. They're too small to recommend a biopsy. But with ultrasound guidance, you can biopsy a 5 or 6 mm nodule easily. I've done it, and I'm not very good at it. Are the ones that do them really well, I mean, they can put that right in the center of a tiny nodule. So, yeah.
So now my new second question, is it a technical aspect that makes it difficult to biopsy less than a centimeter, or is it more of, on average, when you look at all the nodules across the population, most or low risk?
So the question is, why don't we biopsy them less than 1 centimeter? It's not a technical issue. They can easily be biopsied. The issue is that most thyroid nodules under 1 centimeter never do any harm, but any nodule that's 3 centimeters used to be 1 centimeter. I mean, they had to start somewhere. And so that's the discussion. And so I think I have a fundamental disagreement with that. With the guidelines over that type of thing. I think you look at a small nodule, you look at its features, you look at your pretest probability. If this person had a history of radiation therapy, a family history of cancer, they've got a lymph node, you need to modify what the guidelines say, because you're the physician. You're the one making that decision. And I don't think the patient's going to be happy with you telling them, "Oh, this has got a lot of high risk features. We're just going to watch that for a while." Because what if it's colon cancer? The earlier you get it, the better chance you have of curing it. And this doctor that I mentioned, she's out now about 7 years and no evidence of disease. But I think if we had not pursued that aggressively, she may have had a bad outcome. And people do die of thyroid cancer. 95% are cured, but 5% have a progressive and bad outcome.
Another question in the chat. Are molecular markers tested off initial FNA, or does it require a second procedure?
So the question is, do molecular markers, can they be measured off archived material, is another way of saying that, or do you have to do another FNA? So very recently, these companies are all now finding ways to like scrape off tissue from one of the slides and do the molecular testing on it, because they now need lower volumes. And so sometimes it's possible to just use the previous biopsy. What we do, and IR actually is doing less FNAs. For some reason, they want us to do more. We always take an extra tube and we squirt an extra sample into a tube just in case we want to do molecular, so we don't have to call the patient back and do another biopsy. So I think it can be done one of two ways. We do the biopsy and we take an extra sample for molecular markers and run them if needed. But because a lot of people don't always do that, a lot of the companies are finding ways to scrape off material from archived slides as old as several years and still run, because some of them are RNA and it's unstable, but the ones that look at DNA, it's very stable, and they can, reassess molecular markers. Okay. Well, thank you for your attention and for being interested in this. Thank you.